But at the moment, my little worry is that the traditional general practice we're used to potentially could face an existential threat, and that's a big concern to me. And one of the reasons that I want to involve everybody is that I've drafted a sort of rough manifesto, which I've shown to Paul, as to what we might want in this election year from parties about general practice. And so I just want to run some ideas past you all, really. Number one, why are we in this possible, I suppose, existential threat position? And I think there's several things conspiring. Number one, there's always been the naysayers who hate the small practice, self-employed, not being part of a hierarchy model. So there's always that. Some of that from old Labour. But also there's many managers and so on who think that we should just work at scale in some sort of access factory and not provide all the broader things that most of us love about the potential of general practice. So that's number one. But also the Labour shadow spokesman at one time was saying that the partnership model is defunct and should be go, and was quite scathing about the way that GPs are funded. In fact, implied it might not be well governed. So he's rowed back on that, but there is enough, because one of the things that general practice, even though our community pharmacists would argue that they're as equally popular, was that we had very high satisfaction rates in the health service. They've been dropping slightly over the last few years, but we're still by far were the most satisfied by, as it were, by patients. And this year, the latest figures show a remarkably calamitous almost drop. We are now second only to outpatient care, which is, of course, a ration service. But our figures are dropping as the whole health service is, and it's to do with lack of access. Now, general practice is already back to pre-COVID levels of activity and higher. The latest NHS figures suggest that we'll have to offer about 44 more appointments per practice, as it were, per week. And so this is a time when general practice is as worn down as probably any other health system. Our share of the money has fallen now to 8% of the NHS token and a total. And of course, we have to realise that the health service itself arguably is underfunded. So these are just some of the issues that might lend itself to worried about whether our position is sustainable. So how do we, as it were, try and preempt such a thing? Because unfortunately, quite a few GPs I've spoke to, and retired GPs, seem to be looking towards this factory access model as well. So we don't have the uniform support of even our colleagues. Now, my view of general practice has been, of course, you are that personal doctor. And one of the reasons I wanted to be a GP, because I wanted to be a doctor for a person rather than a doctor for a disease. And many of us have come into general practice for that reason. The other attraction for many of us, I'm sure, and certainly me, was the lack of not being in a rigid hierarchy model like a hospital, of having far more freedom and semi-autonomy, which I think I welcomed. And that's what the partnership model lent itself well. And so how can we preserve this? And so one of the things I was thinking of was organisations such as COIN, and I'll be in touch with one or two other NHS organisations like NAPC, which James would know well, and whether we might want to begin to get together a manifesto approach of what general practice might need, because it's far too important to lose. And in this diminishing our role, which even some GPs are supporting, as I say, a service that provides 2/3 of all the NHS consultations, which is enormous, has a shrinking population, the percentage of the budget. And where are we to go from here? Now, my view is that general practice should maintain the partnership model in the way we are funded and working from that point outwards. And that is significantly at threat. And I understand that there's dissatisfaction in many parts of general practice, but that small, local, serving your community is something I think we would lose at our peril. So number one, how do we manage to keep a campaign going to say that's important, which I think is necessary. Second, beyond that, what we tried to develop in the practice I worked in at Castlefields Health Centre in Runcorn was the three aspects was, yes, to develop more and more services in primary care than we used to before, and not just through the GP. The whole point was how you do build a team. And in fact, NHS policy for the last few years have been adding more people to the GP team, but in an uncoordinated way. And maybe the practices themselves sometimes struggle to know what to do with these extra people. But we do need to have a multidisciplinary team serving a registered population. It is rare. It's no other health service no other health provider in this country has a registered population responsibility. And in fact, it's pretty uncommon internationally for general practice. So that's something we need to cherish. How do we continue what has been described the strengths of general practice, which is coordination, continuity, and comprehensiveness? And doing that to a registered population fits it well. Now, one of the work that I developed in our practice of extending primary care, by doing that, being able to reshape some of the unnecessary hospital activity that's going on, and as also building on people like Julian Tudor Hart, Jeffrey, I've forgotten his surname for the moment, near Teesside, Jeffrey Marsh. How do we become much more population focused? We have a registered population, but most GPs don't use it for any population health. So that's some of the issues that we need to, I think, address. The work we did made me develop a concept called a primary care home, which was a home for everybody who works in primary and community services around a population, and got enough attention and fantastic development support from the National Association of Primary Care that Simon Stevens, the last Chief Executive of the Health Service, launched it, and that's where primary care networks came from. The idea of this small enough to be local, and yet bigger than a practice to be more influential in affecting other parts of the health service. The small and big concept, which we need to do. Often we have this rather dichotomous thinking, when in fact we need to do both, think small and think big to be influential. And so one, developing primary care, two, being able to reshape hospitals, and three, having a public health role. Now, in the manifesto I've drafted, it's first of all, it is clear that general practice in itself, given its shrinking budget, needs specific investment focused around the primary care system. Second, how do we introduce incentives at that level so that we can encourage practices to want to do more? And one of the things is, do we have budgets at practice level, or even beyond, as we did in the past? I know budgets in the past were treated with much disdain by many people, but for people like myself, it actually awoke us. We could have much more control of our destiny by beginning to do more in primary care and less need for hospital activity. We could begin to reshape a model where we can put more money into primary care. And as part of that work, how do we as a practice, health visitors and everybody else, have that much more proactive role beyond even long-term conditions care? So that was the model. That's what I think we need investment. One, yes, more money. Two, extra incentives if GPs want to have the wider approach. And for practices who don't want this model, I think they have an opportunity to opt out and become a salaried service or work with some other provider who looks after them, as it were. But I think we need to develop that. And so extra incentives, budgets to begin to look at this more holistic approach, and much more active support for us to get involved in community involvement in ways like we've had in the past from the Peckham project, more recently in Bromley by Bow, and at scale in Fleetwood. And when we were developing the primary care home, it was interesting how many GP practices began to explore, with the excitement of this new approach, began to explore a community involvement model. So that's where I want investment to be and support. And the primary care network, which is above a practice, is not a hierarchical model. My worry is that whoever begins to own general practice or the primary care networks will lapse into a traditional NHS mode of having a hierarchical approach. We're partners with the primary care network. We, at practice level, are the local element of a perfect primary care system, and the primary care network can offer support to practices who need it, do activities supra that the practice can't do as well as being in contact with the wider health service so that we can have that big and little at the same time. That needs development because I think the management style in the health service is generally hierarchical control and compliance. And that is the wrong approach if you want to encourage professionals to prosper. And then finally, I think at some time in this approach of looking at what general practice and others do, I think we need to have a realistic view as to the individual consultation. We've often talked about trying to equalize the power differential. And part of my misspent middle age, I was a local councillor, which many of my patients were my constituents. And one of the things that it awoke in me was that this was a different power base. I was now asking my patients for something, their vote. And I think it made me reflect more on my role as a GP. But one of the areas is that there still is, if you talk to most doctors, this rather dominant role that we know what's best rather than enabling role. And is there some work that the Royal College, which did much work about 50, 60 years ago, about that patient-doctor-citizen interface that we need to work hard at? So my manifesto is improving primary care in the broad sense I talked about, ensuring that primary care networks have the right managerial approach. And we need to begin to explore what the individual consultation focus has been rather than the traditional top-down with your patients. And more fundamentally, which I don't want to start going off at a tangent, but I wonder if our nationalisation model is past its sell-by date for the health service. And we need to begin to look at not privatisation, but these are simplistic alternatives, but a different approach, which maybe many of the countries in Western Europe have gone for, which is a different funding system. Because nationalisation tends to be a much more provider-focused approach. So those are some of the thoughts, Paul. I've just thrown them out there. But I wonder if the manifesto issue could begin to raise some interest amongst COID members too about putting ideas forward, not necessarily all tonight. So now I think
GPs don't necessarily have the opportunity of experiencing some of the enormous difficulties that come with life and health. And we get into such a medical model of trying to find problems and cure them. So maybe the end-of-life home situation, carers of people who are dying at home, could be quite a good focus, both for team working from the various agencies and also teaching those individuals how to manage complexity. And that very same place could become a place where students go to see medical students, nursing students, other students, even school children. School children got remarkable intelligence and empathy that gets rather kicked out of them in medical school, I think.
Very passionate about the partnership model for a registered population. But I think there are a number of advantages, but we need to tweak it. So if you look at the Norwegian model that talks about great relational continuity of care, they have 900 patients per registered whole-time equivalent GP, and we have roughly 2,000. So immediately, we need to get from 2,000 to 900 if we're going to have that same level of relational continuity of care. If I look at younger GP colleagues, really about 10% want to become partners. The other 90% are very happy to just leave at 6:30 and not be open to all the risks of running a general practice. So how do you make the partnership model to the younger generation who perhaps want to work flexibly and have different priorities? Because That is a lifeblood of general practice partnership, isn't it? Getting in new partners who are passionate about their local communities, wanting to serve and live in their local communities. But I do think we should pilot alternative models of general practice so that we can see what are the advantages of the other models. In the last few years is that there's an increasing diversity of the primary care workforce, and I think that's a really good thing.
Actually, this is moving at lightning speed. It may feel terribly slow to us, but actually some of this is going very, very fast. And also, of course, Cuckoo Lane Surgery, which is also in Raj's pact, has got the only nurse-led practice in the country, which got outstanding in the CQC assessment.
Ask the question of what are the obstacles? I mean, one of the obvious obstacles is so many of the things we might want to do cost money. And people may say, well, but we don't have money, we can't afford it. I think we need to start making the case that health interventions don't simply improve health. They can potentially also boost the economy and productivity. Now, a few years ago, we published a paper in the London Journal of Primary Care on what primary care can do to improve the mental health of the working age population. And many of those things, I think, would also tend to improve the economy. We also had a presentation a while back from Hazel Stutley, which described an intervention on which there was a positive economic return on investment, not just a positive health and mental health benefit. So I think that may be a line of approach that could be profitable for us.
Also, remember that actually, if you manage some things in the community better, they actually save hospital costs. When my wife was dying at home, she didn't have a single night in hospital in the last year of her life. Look how much that saved costs. Whereas, of course, you do have to evaluate that. So if we can gather routine data from primary care networks about, let's say, hospital admissions, place of death, and you can actually calculate, use primary care networks as case studies of the kind that Sanjay is potentially describing, showing how different models are actually cost effective and cost less money, but they do require multidisciplinary collaborative work in the type of which David's been describing to us.
Good evening. My name is Peter Whitehouse. I'm a geriatric neurologist based, as Kurt, my friend, is in Cleveland. I was born in London, raised in Newcastle, and when I'm reincarnated, and if I've done good in this life, I will come back as a primary care physician or nurse. This is a bit outside of my scope, but I sometimes think it's important to consider the broader context of the work we're all doing. I do work in public health and in environmental health, and I'm an environmental ethicist. And I do think wherever we are, and by the way, you may have noticed we're in an election year as well in the United States, to count Mother Nature into your future planning. I frankly think that when people talk about things, Paul talks about things accelerating at a faster rate than we expect, that the poly crisis, which is what I'll be writing for the special issue of the journal, thanks to Paul's invitation, is with us and intensifying. And so whatever you do to reorganize the healthcare system in whatever country you are, you need to consider, in my opinion, that broader context. And of course, what that means is, I think I'll just leave you one particular thought. I'm working on scale. So we have to work on local communities, we have to work on network of providers, we have to work nationally, we have to work globally, but Mother Nature operates on watersheds and bioregions. So I think that as you're planning the healthcare system of the future, you will need to think about the ecosystems in which individual practices and networks belong, and that the health consequences of being in that ecosystem, being in that watershed, will drive a lot of what we are able to do in healthcare. And the potential economic collapses and population reductions that are likely to occur in the decades to come will really dramatically affect how we who are desperately concerned about the health of our own patients, our own families, communities will have to.
Actually, since you're speaking there, Peter, that you, of course, set up a whole a load of intergenerational schools, demonstrating the power of schools to improve health.
Yes, they've been in existence for 25 years now. And we've been working around the world, including from time to time with Paul in London and Oxford and Scotland, even the borders. I think as we have these conversations, we're not going to forget patients and families, but we've got to be a bit cautious about thinking about patients and families over time, intergenerational units. And I frankly think in the long term, if we don't educate our children to think differently about health, to get their minds decolonized from the kind of medical model that we're fighting against, that has to be part of a long-term plan. I hope we have enough time in which to invest in our school-based health programs to try to help the kids and the doctors of the future to be less indoctrinated by scientism and everything it's brought us.
Fantastic. And a little anecdote of today, I was picking up a 10-year-old Ukrainian who's staying with us at the moment from primary school this afternoon at 3:30. And we were just leaving and I was saying, oh, what are you doing today? I don't know what's happened at school. And she said, hold on a minute, there's my friend Sophia. And then she ran up to this other girl who was over there and gave her a hug and said, she's Russian. And I thought, what a metaphor for what we are doing in COIN. You provide an environment where it is possible to see people as human beings rather than something to attack.
Very much. My name is Sanjeev Alawali. I'm a GP in North London and I run a medical school in Essex. Thank you, David, for a really, really great exposition. I absolutely love the idea of the primary care home. The challenge I think that exists is that it has become a transactional thing with the bureaucratization of primary care networks. And we need to think a little bit about how we bring some clinical leadership back into that construct. The second part of this is about the relationship between clinicians and their community. How do we reinvigorate moment? And the final comment I'd make is that the same issues around loss of empathy that we are seeing in perhaps the undergraduate spaces in training is being emulated in primary care and general practice as well. And that's a lot to do with the injuries that people are facing, psychological injuries that people are facing from the way they are experiencing work. And we need to consider ways that we can heal people and return them to good health so that they can then serve the communities with passion and vigor. Thank you. Thank you.
Thank you, Sanjeev. A few thoughts, please, about that. How do you get GPs to engage in things other than their medical work? David, I think it's a question even to you. You were very engaged in your community in Castlefield.
I was 11 years a counsellor. And I said it made me think about the relationship between patient and myself because of that it was improved. I just did it, really. I've always been interested in politics. And I was involved locally in the party I belonged to, and an opportunity came up for being a counsellor. I asked my partners if they had any objection. They were a nice group of partners, but some might have found that difficult, but I did, and it was all right. And I spent 11 years, as I said, and there were many similarities between being a counsellor and being a GP. Making yourself available and trying to help people with all sorts of life problems. And so I found that it was quite almost like an extension. But I just did it, Paul. I've always been interested in the public health. And I suppose to be involved beyond healthcare was really important for me.
Quite like other views on this, because I think you knock on the doors and they say, oh, sorry, we didn't call for the doctor.
No, that's exactly.
So actually, no, I'm a counsellor today. And maybe GPs need excuses to be human beings on their patch. Well, I used to in Liverpool when I was there. I mean, I was part of the Open Eye Film and Video Gallery, and used to meet up with the people there on Friday nights in pubs. And in those days, they used to have those little beer mats, the way with a paper. You'd peel them off, and there'd be paper underneath. So I'd write down what they were saying about how health should be changed, stick it in my pocket, and that would be the ideas we develop in our Princess Park Health Centre, as it was then. It was an excuse, an opportunity. Had I not got that opportunity, would it have been quite so easy to get those views? Maybe GPs need excuses. I don't see any hands.
No, but might not need excuses, but a lot of GPs don't want to. It's like a friend of mine said about me when I was talking about my role as a GP, and he said, "So you let them in, David," which I thought was a very interesting point of view, that a lot of doctors are quite frozen, about being, as it were, too matey and out there, and so there is a real issue about the culture of our profession, which in my little presentation, if we ever get that sort of money, we do need a program of work for future and existing clinicians about what their role is, because progressing to an even more distant, let's get them through the door sort of model. So I think some of this is about development work, where we will ever get money from for this, but I do think that working with the college might be one way forward.
I think there's been lots said about the culture. It's very dominant in the discussion we've had so far. And it seems to me that education has to be talked about more in this context. Now, I appreciate, Paul and others, that we need to look at schools. And I'm a governor in a school, so I know something about that. But I actually think, being practical, the areas we need to tackle are the areas that Sanjeev's working in, medical education and other professions, getting into the culture of the professional education, not only of doctors but of other professions as well. I'm talking about developing them around communities, around patients, around people, and also working with learning rather with, from and about other professions to enable them to work more effectively in a multidisciplinary way. I mean, Miss Jean Brodie did say that the purpose of education was to put old heads on young shoulders, and I'd like them to, perhaps we should think about putting middle-aged heads on young shoulders and getting more David Tomey's approach to the way in which doctors, young doctors coming through the system, start to think about themselves in the context of the community. And I just think they need the skills, and perhaps the role models would be really important as well. And, what can we do about medical education and the other professions? And I stress the other professions as well, because I think that's an important approach to open the door to not only the patient and the family and the carers, which are really important and central, but also to recognise that it's not only the doctor that serves those people, and how do we work together more effectively. I think there are models out there in medical schools and other universities, but I wonder if we could perhaps develop something which is more immediate and more transformational.
I'm nearly Norwegian, but I'm actually Danish. But yeah. But it used to be the same country, but it was some 100 years ago. but you're right. In Norway, they only have about 1,000 patients per GP, and they suffer from burnout. They suffer from having too much to do. I don't think that the issue is how many patients you have listed. It's actually whether you have discussed what should we do as a GP and what's not necessary. And we haven't had that discussion yet in Denmark, but I'm quite sure that we will have to take that discussion. Because, it always builds up, then it's we do a lot of work for insurance companies, and we do a lot of clinical work that's unnecessary, controlling hypertension 3 times a year and all that. And I think that's pertinent for all countries. We need that discussion. What is the general practitioner's work, and what should we leave to others, and even to the patient?
Thanks. I think in terms of the 900 patients per registered GP in the Norway model, I mean, the primary driver for that is so that a GP can provide the relational continuity of care. And I think for the UK, that is the way forward. So I think we should forget about this 2,000 per GP and move to the 900 per GP. And how do we achieve that? Well, it's very simple. Look, right now, we, in our primary care teams, in my primary care team, I have a musculoskeletal specialist who sees knee pain, back pain, acute musculoskeletal conditions, and that provides me extra capacity. I have clinical pharmacists in my team. I have social prescribers. I have mental health specialists. And additionally, I have paramedics in my team. And all of these key people have been given to me as a PCN resource.
My name is Janus Laus Thomsen, and I'm a GP in Denmark and a professor at Aalborg University. Well, I'm not from Norway either, and also from Denmark, and we're talking about the Danish model as well. And in my area of Denmark, we have 1,800 patients on the list, and still we managed to have a very good model. Of course, more people in Denmark among the GPs are also facing burnout and dissatisfactions with their job, but the majority are very happy about the job. And I think going back to some of the things that Linda said, that we have a very strong foothold in education. So general practitioners at the universities are having a lot of the education of the GPs to come, and we have very strong GP networks. And I think working in GP networks, and of course we need time to build the GP networks and to participate in the GP networks. So having a lot of other like nurses, social workers, and so on, in working in general practice may bring in this needed time and extra resources to engage into GP networks. So we have these GP networks, which is very strong in quality development and continuous medical education, which I think is very good for general practice. And we try to be more like clinical leaders, opinion leaders as well. And I think that's very important as well. And what I see from this discussion here is what you are trying to do more. And I think looking at England when I was a young doctor, I think you have a very amazing model. So it's quite scary to see how it's going downwards.
We're exploring here a little bit about how can GPs be medical doctors, physicians looking after patients with medical problems, and also generalist human beings who can knock on people's doors and people think they're counsellors or in a pub somewhere as human beings. Louise.
Hi there. Yes, I'm GP very part-time, so I'm a retainer and Prof of Medical Education at Queen Mary, University of London. That's Barts in the London. So I had to run downstairs because the dog's barking. It's a bit dark here, but anyway. So just to say on the one side that I am fully aware that working in general practice is tougher than ever. Having done it for 20 years, I'm sort of struggling more than I ever have, but perhaps because I'm working very part-time. On the other hand, I'm doing a lot of work in medical education and with clinicians around the human dimension of healthcare. And human flourishing. And the work started with trying to humanize the patient and sort of thinking about person-centered care, often using creative methods to create spaces to share our lived experience. So using other languages. And then I realized as I humanized the patients, we humanized the students, and they started sharing about their own challenges and around imposter syndrome and around, fears and struggles. And I think I do a small group, creative arts, with a group of 12 students over 20, I've been doing this for 20 years, for 2 weeks. And I think my last group of students, maybe like picking up what Sanjeev was saying, I've never known them to have so many challenges. So one had suffered homelessness at some point. There's a couple of people with chronic illness. There was, I wouldn't get so much into all the mental health, although we do sometimes, number of them carrying anxiety and stuff. So I think that the students are coming with more and more burdens. We need more and more to be done. And I think it is possible, but it takes time and energy and space and valuing this dimension. I think there's more openness than there has been in the last 20 years to this kind of work, philosophically perhaps, but then there's other drivers pushing in the other direction, like the new medical licensing assessment. So,
Louise, can it be taught and at scale?
So we can make spaces. So I'm doing a lot of work thinking about flourishing spaces actually across higher education. And I think when people, so my experience with small groups of students, when they are in spaces where they can share and be honest and build trusting relationship. So say we take our higher education and we help people develop the relationships between people, so you have 10% more trust between everybody. What happens is, you know, huge in terms of just having a friend or a support or whatever. So I think I think we need to stop talking about resilience somewhat and start thinking about the relationships between, and that's where I sort of talk about flourishing and growth, because resilience is often marketed as a sort of toughing it out yourself and being really macho and strong, and that just contributes to all the, you know, the high suicide risk and the liver disease that we see amongst clinicians. But actually, we need to start thinking about the relationship between and how we build and develop that relationship. And so I think we need to co-create with students. So co-creation is probably the only way forward because, you know, they're a different generation to us. So I think things can be done at scale. There needs to be the will, there needs to be the drive. It does take a lot of energy and openness to it. And we're just aware that there are other drivers. And I did, just to finish, I suppose I did a keynote at Warwick on human flourishing for both consultants and GPs. It was a joint education conference. And there was probably a fairly burnt out consultant who was, and actually a couple of people who were just saying that if you do that work with the students, when they hit clinical practice, is that how are they going to survive if you kind of humanize them too much, because they're sort of feeling, I suppose, burnt out and that struggle to be human because of the systems that we work in. It's a bit chicken and egg, you know, maybe if we change leaders and management, I'm not sure, but there are challenges.
Yeah, I don't agree this can be done at scale. I think with all the evidence now is that with everything that's introduced at scale, it doesn't work. I mean, the King's Fund House of Care was a great example of a lot of work that went into having one wall of the house with patient involvement. Nothing could come of it. I think if anything like this is going to work, it has to be done on a very small basis to begin with, and very differently. I'm very suspicious of my own thoughts because I'm also called David, and my heyday was in the 80s and 90s when, as your David says, we just did it. We did it. It was, circumstances were such that we could do it. We didn't really worry about money. We had enough money. We didn't have any legal challenges, hardly at all. We did diagnose and do a history and examination because X-rays were considered too expensive. We didn't have anything like the technical knowledge that is needed now. I mean, I saw a CPD of 2 hours to talk about how to deal with blood tests which are abnormal. Well, we only had 3 or 4 blood tests, and we thought we were hard done by doing night visits and delivering people at home and so on. But these were all the time bringing us in contact with patients. We were dependent on our patients. We were dependent on ourselves. And now this is a completely different generation where all those things come as forces against us. And if a project like this is going to go beyond thinking, it's going to mean sacrifices. And you can't get people to sacrifice things at scale. We also had examples of people who I used to look up to and were my heroes. They were amongst the patients, but they were also amongst my colleagues. We met regularly as colleagues. There's no question about not having somebody come to your home or come to your practice because they were needy, but they didn't, because they said, Dr. McGavin's got a weekend off. I'm not going to bother him, because they knew me and I knew them. So it was a very different world. And I think the sacrifices that will need to be made are too great for many people now. And when I say sacrifices, of course, sacrifices only hurt until you become a missionary. And when you have a missionary, as I can see, we've got 1 or 2 here, sacrifices are no longer painful. They become a joy. You actually love doing what you're doing. You don't put any amount of work into it. You don't mind giving money away or handing this over or that. This is not the culture now. This is a very adverse culture. And I think if anything like this is going to work, and it twangs so much for me of the good old days, it's got to show itself as an example of working in 2 or 3 places and growing from there.
I'm Dave. I'm a GP and I work at Imperial as well. I think it's, as people have said already, it's a really challenging environment to be a GP at the moment, just for various reasons. It was much more straightforward, 15 years ago, when everyone just came in and everyone did the same. I think one of the challenges is different generations want different things, the patients we're dealing with. So, I mean, the sort of, people in their 20s and 30s, if you suggest they take a bit of time off work to actually come and see the doctor in person, it's like you're suggesting something sort of outrageous. So it's whereas the older generations, maybe people in their sort of 60s, 70s do want to. So different generations want different things, which I think you have to sort of take into account when dealing with the patients. And that means you have to have a lot of conversations about the mode of consultation, whether people want to come in. And actually, a lot of patients are now quite confused about what they actually need to come and see the GP about. The digital things, despite all the advantages of, text message and so on, what's happened is that GPs are now in this sort of constant digital dialogue with patients. You get a message, an email back an hour later saying, my tummy pain's got a bit worse, it's got a bit better. So your days as a GP are this sort of prolonged digital exchange with patients, sending photos, doing this, which it didn't used to be. In face-to-face, it was much more clear-cut. And I think that's what's burning people out, that this high volume of text messages, emails, pictures, etc. It's just relentless.
Thanks very much. Gosh, as I sit on the outside of the tent now, looking at what you're contending with, and knowing that I couldn't do the job anymore, and knowing that the evidence on what helps doctors flourish, one of the key elements is the joy of working with some patients, and the ability to restore oneself by having a life outside medicine. As I hear what the challenges are, I mean, the polycrisis certainly, because what's happening to medicine is a reflection of what's happening in a increasingly unsustainable car crash of a culture. But neoliberalism, the polycrisis, the obvious need for culture change, but I don't think it can be confined to medicine. And therefore, as David McGavin says, the idea of doing this at scale, it seems to be unlikely. Whether you can create policy and strategy at a high level to somehow shift the system into being more human, it kind of like fighting for peace, isn't it? It's not really going to work. But how can we do something locally, given, well, once we accept that the NHS is collapsing? And I go along with Jem Bendel, who is really an ecological scientist based up in the north of England. But his point is about something called deep adaptation. And if we look at his 4 R's, I do think we need to hold on to resilience, whether we call it flourishing or not. It is about healthy adaptation to the challenges that we face as individuals and as teams and as a medical culture. So how do we keep our heads above water as practitioners and as patients in these strange times? So there's something about how do we create resilience, and how do we help our students to know something about emotions and something about the complexity of health and healthcare very, very early on, before they get embedded in the idea that everything can be fixed. We can fix things. I was talking to Sam Everington the other week, and I tend to agree that 80% of what we do in general practice has got absolutely nothing to do with biomedicine. And then what about reconciling? Well, we think, how do we and our patients and the culture reconcile ourselves to the fact that human beings are limited, vulnerable, and dependent? And we need to to be much realistic about our own humanity. And I think in terms of medical education, could begin by those of us who teach medicine admitting that sometimes we're wrong, we're hurt, we need a Schwartz round, we need a ballot group, and as Paul suggests, we need to hang out with people who aren't embedded in this very strange armored culture that we've learned to live in, probably to our detriment. At small scale, I again talking to Sam Everington, he says there is a group in Tower Hamlets of idealistic primary care people who support one another and are creating a really revolutionary approach to community healthcare. And I'm sure you'd know more about that than I do at this point, Paul. But there are models, and let's start on a small scale and learn from them.
Just before James, I want to point out that you were getting hearts of agreement there, David, and also Catherine, Ingrid, Tony, Annette, Kurt. We've only got 10 minutes left and haven't heard. James.
Hi, everybody. Thanks, Paul. I'm still catching up with DCT, still aspiring to him, but I'm up to 40 years in the NHS now and not in clinical practice. 32 years in general practice, but still working on a number of national programs. And I thought I'd just say a bit like maybe a Dragon's Den, where I am, not quite in the final throes of having some significant influence, but over the next week or so, I am meeting with two ministers. I'm giving advice to an APPG and meeting with the Department of Health tomorrow about the future of the general practice contract on a one-to-one with the lead of that. So I thought I'd just test what I'm going to be saying, and I think it aligns with the approach COIN is taking, in that whilst I loved my time in general practice, I do not believe the construct of general practice as it is at the moment has a future. The primary care home, which DCT described in a paper 2011, we brought to the fore in 2015, and it said that the general practitioner, the primary care physician, is a vital part of a team-based approach to the needs, yes, of a registered population, but doesn't have the wide skills and competencies. And we've almost seen the GP drifting into all sorts of areas of care that, unless they have the specific skills and competencies, shouldn't be doing, but they should have the team to do it. I've presented, and I know not many will have been on the call, but I presented almost the next stage of what the primary care home might be doing if it had matured to look after the most complex areas of care in our society today, and that's this complete care community programme. And what that is revealing, and it is a policy advisory programme, is all sorts of things where the GP, the primary care physician, is vital in the future, but not in the construct of the current general practice. I'm not saying that we shouldn't have the partnership model. I'm not saying there shouldn't be an independent contractor, but the idea that the modal or the usual size is still a general practice with a supporting nursing and administrative structure is the mainstay, and we're trying to stick those together in a primary care network. I don't think that's the future. It's about being in a multidisciplinary team that's looking after some of the most complex areas of care. So the work I've been doing, I've already reported, I'm seeing the Department of Health tomorrow. They said, what is the biggest barrier to look after some of the most difficult areas of care, the health inequalities? What is the biggest barrier to delivering against it? And I said, the answer is the GP contract. The senior civil servant said, what are you saying? I said, get rid of it. And he went, interesting, we're thinking about it. So I'm going to be pushing for that. I think the mechanistic, contractual way we are delivering care in general practice isn't fit for the future. And some of the meetings I'm having on a daily basis with primary care network leaders, healthcare professionals, health and social care professionals in networks who are doing some fantastic work, as I say, after 40 years, I'm just going, wow, all the time. And they're finding ways of increasing cervical cytology uptake in those groups of women who are going to get cervical cancer but do not go for cervical screening. They're finding ways to increase MMR vaccines when we're seeing, we're now having measles epidemics, and they understand why we're having it. And it's not going to be improved by general practice sending out more letters or texts to say, please come for your vaccinations. It's going to be a very different approach to community-based, population-based medicine, which is still list-based and still has the general practitioner as a vital part, but we need the GP, the diagnostician, the coordinator, maybe the referrer. But I thought the time won't allow to go into detail.
One thought I just want to throw in is that supposing we require GPs to be generalists, not pretend specialists, but actually they understand multi-paradigm research and systems of care and relationship building and the theory of community development and multidisciplinary team working and so on, which are all not, as James has just said, not taught.
Yeah, I think that's the point I was trying to make earlier and others have made. And I noticed on the chat that I think it's Louise and Yanis have had a discussion about the way in which medical students are taught in Denmark. Yanis, you made some reference to it that Louise picked up on. It does go back to the education of individuals, though, doesn't it? It doesn't just, we can't get this transformation to occur without educating people appropriately from the outset.
Hi, my name is Catherine and I'm a Danish junior doctor and soon to be PhD student at the University of Southern Denmark. And I spent the last 2 years working in GP offices in Denmark and Norway. I would just like to piggyback, back up some of the points that's already been made of time, because my biggest concern with trying to be the doctor that I want to be is not having the time for it. And I think that we're missing some really, really important workforce in midwives, in nurses and so on that could be drawn in to the GP to free me some time to actually engage with my patients and be way more present when they've waited 3 weeks and come in with 3 different problems and I don't have the time to speak to them as a human to human, and it's more of a race of getting through those 8 hours of 15 minutes back to back.
So I'm a nurse, so come from a different professional level, and lots of what you've said, I think, is in not just in medicine, but it's in nursing too. I liked the things Louise was saying about how you teaching people an alternative to being resilient, but I always think there's that massive thing. I was involved in pre-reg nurse education until quite recently, about that gulf between what you teach in university and in the room, people seem to embrace it, but there's this big gulf between there and what they see in practice. They're working alongside people who are pushed for time, and so many people are quite burnt out that, so that was one of the things. The other thing I had on here was about thinking about where we got our role models from. So if we think that this is really important, have we seen role models that we've experienced in our own clinical practice, and where did we see them? So people who believed it but also kind of lived this as well. And I think it's really important to think who those people have been, maybe for us, that we've seen along the way.
Some quickies first of all. I'm all for different models of general practice, but I do feel they need to have a population base. And the Davids were a group united. Smallness is where it happens. So when you talk about scale, I worry, because everything, complexity and paradoxes and dichotomies are much more sorted out locally where you've got relationships. So it's a bit about that relationship building, which we've talked about already. One of the interesting things is, over the years I was a GP, is the consultation is a conversation rather than a consultation, if I can try and make the subtle difference. And I think that a lot of doctors struggle, partly because I was a waster at medical school. I didn't have the inculcation of all these bloody teachers that we had, which taught us to be elitist somehow, I think. And I just wonder if we just need that different approach to the consultation rather than this formal, rigid way which we are taught. And part of this more human thing, so localness conversations, is, when people are saying it wasn't like it was, I think in many ways, and this is true of hospitals, we've given it away. We may feel hard done by, but it's hard to think of anybody in this country who, as a group, has more locus of control than us lot. So why haven't we used it? Why have we ceded all the bits that we liked about previous general practice and absorbed the new technologies and so on? It's easier to have impersonal conversations with patients or by text and things when you know them already. Then it doesn't matter. So I wonder, our conversation element, we need to think about that patient contact bit rather than the formal top-down way. And part of this is also, us all as clinicians use our locus of control and power. For goodness sake, we're giving it away and saying it, blaming it on others, it strikes to me, which seems a very negative position. So those are just some thoughts about how can we change the culture. But I do think I agree, maybe it's my age as well, that localness is the only answer. And that's tedious maybe for some, and local and not a spectacle, and politicians and managers won't like it. But if we're going to make sustained change, we've got to do it that way.
And on that challenge, we have to close this formal bit of the meeting. I'm so sorry we started late. It was all IT's fault. So there you are. We are, some of us, going to carry on for another 10 minutes or so, working out what on earth we're going to be doing next. This is one of the problems of this organic way of operating. We have no idea what the next step brings, but it's usually rather fun anyway. Make sure, if you want to stay involved in COIN, that one of us, that's Lucy, myself, Linda, Chris, have got your email address, and just say you want to stay involved, and they get on the routine mailing list. And if you want to stay involved in this debate, let one of us know too, and we'll find a way to make that happen. And very aware that the people who on this call even now know an awful lot about this territory, only some of which has actually come out. So let's please continue this debate behind the scenes. We've got great people in the COIN network.